I appreciate the opportunity to be here, and we're going to pivot a little bit. And I also do a lot of MSK embolization, but the other hat that I wear in my practice is obviously we all do a lot of general embolization, but then I do a lot of liver cancer therapy. And really this space has evolved to ultra-selective delivery of our therapies and embolics, and so we'll go through some of that today. So quick disclosures. And then it's always nice to start with the case, right, to kind of solidify and drive some of this home. And I don't think I have a laser pointer, I apologize, but you can kind of see this is a post-stroke patient, had a G-tube placed, and you see the contrast blush literally right next to the G-tube there anteriorly. I think I have an arrow, yeah. And this is actually the second time I was on call this night. My partner had taken the patient for angio a couple of days prior and had taken down the inferior epigastric artery on that side and the superior epigastric artery on that side, and this patient was still bleeding. So I went, my plan was to actually take down the left gastric and or the gastropoploic. The challenge was for this particular patient, as we rolled through this coronal scan, he had a history of a coarctation of his aorta and a bypass graft, and he had no celiac artery origin. And you see a very, very large SMA collateralized to take over the celiac, and you see the blush here posteriorly there, or anteriorly there, sorry, right next to the G-tube balloon. So not the most straightforward catheterization. This was the initial arteriogram. You see the well-developed pancreaticoduodenal arcade to the GDA, very tortuous, supplying that entire territory. And again, so my plan was left gastric and gastropoploic. And so those of you that know me, my starting catheter, except in very select situations, so like proximal spleen, internal iliac embolization for trauma, maybe variceal bleeding, BATO, BRTO, I might start with a 2.8 microcatheter, base catheter, microcatheter combo. But everything else in my practice, I start with a 2.0 or below. It's very common for me. You get great injection rates. I can get anywhere I need to. I can deliver most of the embolics that I need to. And I'm a primary liquid user at baseline, outside of the MSK space, right? So I started with the 2 French catheter here. And that catheter tip is all the way in the left gastric branch. I couldn't get the 2 French catheter to go. So I pulled everything. And I went back with a 1.9. And I still couldn't get it to go. And I pulled everything. And I went back with a 1.7. And that's how I finally got there, right? So only able to get there with a 1.7 catheter, used lava, embolized, went back to the gastropoploic, didn't see a blush here or a bleed here, actually from either side, but this guy was in extremis. The catheter tip is all the way out the gastropoploic. This was a 1.9, embolized with lava here as well. And then on the post-run, both the gastropoploic is truncated and the left gastric is gone, and this patient got a little bit better. So, but challenging case, different tools in the toolbox, moving away from that standard. I'm going to start with a 2.8 or a 2.4, right? That would have added a lot more time and failure to this case. So, we all talk about ALARA, right? That's a radiology thing. And so this has been coined CASAP, or catheterize as selectively as possible. I'm very curious if Oz is going to like this acronym or not. I haven't showed this to him before, but we'll see. But we know this, right? Better outcomes, less non-target embolization, and really in that era of ultra-selectivity, it's 2 French or less, right? And we are there, we have those tools. And looking at this particular article from the Journal of Japanese Radiology, selective embolization is specifically tied to optimized prognosis and survival, right? So again, we have data that supports this. So the catheters that I have on my shelf, the Asahi Volute, 1.7 tip, 0.17 ID at the tip, accepts an 0.16 wire. I prefer the angle tip, but the straight tip is available. And then the TELUS, which is the 1.9 catheter, I have this on the shelf as well. 0.19 at the distal end, also accepts an 0.16 wire. Again, I prefer the angle tip over the straight tip. We'll talk about why in a second. And then a braided shaft, right? And so this braided proprietary technology, thick wire, thin wire technology, allowing for flexibility, the lack of kinking, lumen retention, and optimized pushability as well. So a quick note about the power or optimizing flow rates. You would think, 1.7, 1.9, well, I'm not going to be able to get great contrast runs, but as you can see, even with the 150 catheter and an IsoView 300, you can get 3.2 cc's per second through the 1.7. Compatibility is important when we're talking about small catheters. We don't have a lot of coil compatibility, but particles in particular, Embospheres 5 to 7, Embozine over 500, but compatible with both catheters. Again, I'm a primary liquid user, so I'm using a lot of liquids in these situations. And then what's the data, right? We all want data around these kinds of, as we evolve in these spaces. And so there is some data. And so these are a couple of series out of Japan. Leave it to our Japanese colleagues, as in the MSK space, to really pioneer the direction that we're going, and then for us in the US to continue to follow, right? And so 9 patients with GI bleeds, 1.7 microcatheters, 0.5 millimeter diameter blood vessels, all successful. Another series a little bit later, 17 patients, again, 1/6 triaxial system or 1/7 microcatheter, slightly larger vessels, again, 100% technical and clinical success. What about cancer therapies? This was 36 patients, 68 tumors, 1.9 French microcatheters, ultra-selective TACE successful in almost 99% of vessels, right? So they picked off individual vessels as opposed to giving segmental or lobar TACEs, right? We know that is less optimal, worse outcomes for these patients. We have to be more selective. You can get selective and be successful. CPN, why is this relevant? We'll talk about this in a couple slides, but this is ultra-selective TACE with basically a RAD path study. And so when they explanted these tumors, 7 of 9 have had complete pathologic necrosis, which is very high for TACE. Those of you that have seen the TACE CPN data, that's very high for TACE. And when they looked at the Lipiodol retention in the tumor, grade 2 portal vein staining actually correlated with normal liver parenchymal necrosis around the tumor, effectively a TACE margin around the tumor, which is what we shoot for with thermal ablation and sometimes with Y90 as well. What about hypovascular tumors? We had a great data set that came out earlier this year from the University of Colorado. Hypovascular on cross-sectional imaging does not equal hypovascular on arterial cone beam CT. We all know that, right? We've all been in that situation. What happens if it is truly, truly hypovascular? Then you get ultra-selective, you deliver your embolic, and it can change the TNR. We know that. Some of Shamar Young's work, actually with Jafar, you can optimize your TNR by being ultra-selective or super-selective. Same thing here. 68% of these 47 HCCs, they got super selective, delivered TACE with Lipiodol, actually able to paint the entire tumor and treat the entire tumor. Guidelines, right? Again, overseas, our international colleagues are a little bit ahead of us with this space. This is from the Korean Liver Cancer Association 2023 expert consensus recommendation. Specifically, 1.5 to 1.7 microcatheters should be primarily used for super selective TACE. Nothing above 2 French should be used, and TACE should be conducted as super selectively as possible. When they polled and surveyed their providers in the country, the vast majority of them, greater than 90% of them, are using 2 French or less microcatheters. So it's already happening. We have to catch up. So then back to CPN. This is the relevance, right? CPN is the important endpoint that we are now aspiring to. It's not just radiologic response. It is truly CPN. So this was a TACE study, initial responders, objective response, and initial CR on imaging, portended better outcome, even compared to later responders or later complete response, right? Specifically related to CPN, these are 2 large cohorts from Agopian et al. And Denorsi et al. Over 3,000 patients, all had HCC, all had local regional therapy, all had transplant. What you invariably see is that CPN after local regional therapy has better overall survival, better recurrence-free survival. So that is the target, not just complete response on imaging. What about for Y90, right? Y90 is now the primary bridging therapy in the U.S. This is what we're all doing in the U.S. As a first-line therapy. This is a nice recent study from the WashU group, 38 patients, 16 of them in that ALB-2B category, 42 tumors, mean perfused volume, very small, less than 70 cc's, very high complete response rate, high pathologic necrosis rate, very little change in lab. So very much a ablative liver-sparing therapy now, right? So the challenge is, how do you convert Y90, though, to this ultra-selective mentality, right? And if you look at the GLASS Y90 IFU, it specifically says greater than 0.20 microcatheter, which is basically 2 French or greater, right? And not all 2 French catheters are also made the same. So we looked back at our own data, and we're commonly using 1.7 and 1.9 catheters in this situation. So on the left side, this was a lady with colorectal mets that I treated, multiple lesions. I gave 4 selective doses. One through a 1.7 Asahi microcatheter, 80 cc of perfused volume, 10 GBQ vials, so that means 2.5 million particles, more than 99% of the dose was delivered. On the right side, it was a 1.9 French catheter. This was a large 14 centimeter cholangiocarcinoma that I treated, again with multiple ablative selective doses, 160 cc perfused volume for this target territory, 13.5 GBQ vials, so 3.375 million particles. Again, over 99% of the dose was delivered, right? So you can go below, although it is off-label, you can go below and make this work and get more selective. What about triaxial systems? This was a nice little paper from 2022, a coaxial microcatheter system through the base catheter. To my knowledge, something that's not available in the US yet, but hopefully we do get to this eventually. A 1.6 inner microcatheter over an 0.14 wire inside of a 2.8 microcatheter. Improved stability, improved torqueability, and then preserving your outer microcatheter in a super selective position, right? When you're using a liquid embolic, when you're using a radioembolic. So that's a really nice advantage to have once we get there. In this study, they also, of the 10 procedures they did, all successful. Actually, one was a resin Y90 delivery. So nice to know that as well. And then I think floating microcatheters. Again, off-label. Hopefully this plays. Maybe this will play. There we go. So again, off-label, we talked about it already, and I do this all the time in the liver. This is my preference. I will get my base catheter to the place it needs to be. I will push my microcatheter in, and if I can navigate, now it is not one-to-one torque, but if I can navigate to where I need to be, I will save time and have a more workflow efficient environment in my angio suite, right? So commonly doing this to the best of my ability, and that's why I use that angled tip like I alluded to earlier. So in conclusion, ultraselective needs to really now be part of the repertoire. General embolization, MSK embolization, tumor embolization, absolutely. Really need to have those tools on the shelf and know when to go down those roads. Compatibilities, I think we still need to learn a little bit more, so those will be hopefully coming soon. And then obviously there's the balance of trackability and torqueability, right? And I think that's where that floating of your microcatheter comes into play. Again, I tend to do that a lot. Hopefully we'll continue to have iterations of device that enable that as we go forward, and then same with coaxial systems. Thank you to my team, right? Everything is always a team. Oz mentioned that, Dr. Okuno mentioned that. I have my interventional radiology colleagues, I have my radiation safety colleagues, I have my nuclear medicine colleagues, and then obviously the ASAE team. So, thank you.